Good morning, everyone. We'll be starting on a topic which has been a bane for everybody for years together. And to convene the session, we have none other than Dr. Ram Chaddha. I would like to introduce him and call him up on the stage to take over. And we have Dr. Kshitij Chaudhari, who is going to introduce the speaker and run through the session.
Much. Can we have the slides up, please? I welcome all of you for this very interesting session on low back pain. Where are we going wrong? So as we all know, low back pain, especially the kind of back pain that is not associated with any specific spine pathology, what we call as non-specific low back pain, is one of the leading cause of back-related disability in the world. And not surprisingly, the economic burden of such kind of back pain is also one of the greatest among all other diseases in terms of direct and indirect costs. There are several challenges that have been highlighted by this article in Lancet, but we as doctors who treat back pain on a regular basis, we need to be aware of certain health care related challenges that we face when we are treating these patients. What we want to impress upon you today is that disabling low back pain is partly iatrogenic, and that some of the healthcare interventions that these patients have can lead to harmful effects. This is essentially reflected by a change in perception of low back pain being a benign part of life to something that requires more and more medical attention, which leads to unnecessary imaging, ineffective and potentially unsafe treatment, which can harm the patient and obviously waste resources. What studies have shown is that with improving social and economic conditions, the incidence of back pain, although it reduces, but as the economic condition and social conditions of countries improve, there is increased expectation and demands from the medical community for treating these back pain, which can lead to a lot of unnecessary interventions that has actually caused an increase in back-related disabilities in the first world countries. This is so-called the back pain paradox. So the learning objectives of this session are to identify how inappropriate healthcare can lead to deleterious effects, differentiate benign low back pain from more serious causes, avoid unnecessary imaging for benign back pain, learn how to explain MRI findings, understand what constitutes as appropriate care, and recognize clues that identify patients who are at high risk for developing chronic pain and treat them appropriately. For this, we have an esteemed panel of speakers. We have Dr. Agnivesh Tikoo from Apollo Hospital, Dr. Nandan Marathe from Fortis and from Raheja Hospital, and Dr. Heath Matthews is the sports physiotherapist who is going to join us from Australia. He has a practice in Khar and has a wonderful online app for treating such patients. And finally, our own past president of Bombay Orthopaedic Society, Dr. Ram Chaddha. So we'll go and start off with the session. And initially, we are going to start off with a small skit, and I'll invite Dr. Nandan Marathe, who's going to act like a doctor, and I am the patient.
How can I help you?
Oh, doctor, I have got very severe back pain since the last 7 days, and I think I have permanently injured my back with something.
Okay. Did you have any fall or injury before which the back pain began?
No, not really. I did not injure or fall, but I was maybe moving some furniture in the house 7 days back, after which I got a small catch. That day was fine, but the next day the pain became very severe, and I think I have caused some damage to my back by doing that.
Is there any activity or position that makes the pain worse?
Oh, right now I have pain in almost all positions, standing, sitting, sleeping. I am spending sleepless nights. I have not gone to work for the last 7 days.
Anything that you do which relieves the pain?
If I lie still in bed and if I don't move, then I'm relatively fine, but even slight turning in bed causes me severe pain. I toss and turn in bed and I'm unable to sleep at night.
Okay. Is this the first time something like this has happened, or you had similar issues in the past?
No, I have never had something like this in the past, but this is something that the pain is so severe that I can't imagine. It's causing me a lot of problems.
Do you have any history of other medical issues or surgeries? Do you smoke?
No, I am relatively healthy. I have no problems. I have never had any surgery before. I do smoke occasionally, 1 or 2 cigarettes maybe a day for the last 10 years. But what I am worried about is, my father had a similar back pain problem and he had to undergo surgery for it, but he never recovered from it. And he is permanently disabled. And I think I'm going to face the same problem. I'm really scared.
Is the pain restricted to your back or does it go into the legs? Do you have any numbness or tingling in your legs?
Not really. The pain is restricted to my back, but it is very, very severe. And I am afraid I have caused some permanent damage to my back.
This really sounds something serious. I think we need to get an urgent MRI to assess the cause of your pain.
Okay, really. Thank you very much. I'll get an MRI done. I'm a really bad actor, but go to the next session. I'll invite Dr. Agnivesh Tikoo, who is going to take us through this, the next talk, which will be on red flags and how we assess benign from serious back pain. Agnivesh.
Just recapitulate what has been shown to you, and this is something that happens in a large number of clinics every day. Keep it at the back of the mind and listen to what Agnivesh has to say. All yours.
Thank you very much, organizers, and thank you, chairpersons. Since Slido is not working, so we'll use Hando. So how many of you agree that the patient has got a serious pathology? Just a raise of hand. Like, who agree that he has got a serious pathology? And those who do not agree that he has got a serious pathology. So clearly, he does not have a serious pathology. And that's what I'm going to take you through, is that are these red flags really red? And when and how to interpret it. We know it's a very common problem to have back pain, and clinical evaluation is the key. When Christopher Hawkes wrote this editorial in Practical Neurology that I've stopped examining my patients, what he meant was the history is so important that he can localize the lesion or the disease just by getting a detailed history. But this invited a lot of backlash from all over the country, saying that you cannot not examine a patient, but that was not the intent. However, the reason why red flags were introduced were to let the general practitioners know that these are the signs when you should not miss and you should seek an urgent referral. But we, as in clinical practice, follow these red flags, and there is a huge list of red flags which has been described based on the pathologies. So the common ones include the thoracic pain, pain at rest, or the night pain, numbness, tingling in perineum, fever, and extremes of age. So these are the common ones which we have to keep in our mind. But what is the actual productivity in real life is something which we look deeper into the literature, and then we identify that individual red flag, like just age over 50, may have a probability of diagnosis of any serious pathology just 6%. But once you have it combined with a trauma, it increases to 11.4. Night pain in an otherwise absolutely healthy patient may be just a part of the disease or the injury or the sprain process itself. But night pain in a patient who has had an infection recently or he is a known case of cancer has to be looked seriously. So this led to the combination of the red flags. Like when you look at red flags, try to analyze them as per pathology, the common ones being the fracture, malignancy, infection, and the cauda equina. So you specifically look into the clinical diagnosis, what are you trying to diagnose in this patient, and then analyze the red flags and see if they combine. If 2 or 3 or more red flags are present, it would mean a serious pathology. So let me give you another example. Back pain in a patient of fever may be 96% non-specific. We have got breakbone fever, we have got a lot of diseases which cause back pain. But in a patient with infection, it would be serious, and that needs to be taken with very careful. So there was a study which was done where 46 red flags were studied with respect to these 4 pathologies, and the accuracy for recommendation of red flags was lacking, that you could not recommend that if these are there, then the disease is more specific. Now look at this, another study, 1,000 patients, red flags were in 69%, 14% 4 or more red flags, 55% 1 or 3. But even all of them, 80%, it was just a musculoskeletal cause and not serious pathology. So there was something which we called as which they devised as the likelihood ratio. So if it was more than 5, it would increase, it would mean a serious pathology. A serious pathology, non-spinal, fever, tuberculosis history, renal stones, dissecting aneurysm, urinary symptom, flank pain would mean a non-spinal serious pathology. But saddle anesthesia, history of tuberculosis with back pain, intravenous drug use, acute onset urinary retention, and loss of anal tone on PR examination were the key red flags which you do not want to miss in a patient who is presenting to ER with severe pain. So the take-home message is that clinical assessment is the key. Presence of red flags does not always mean that the patient has a serious pathology. Even 1 or 2 red flags may be just incidental. More red flags would mean more serious pathology. Think of red flags from a clinical diagnosis perspective rather than individual ones, and nothing can replace a clinical acumen. Thank you very much.
Yeah, I think we'll move on to the next scenario, and I'm the patient. I have got this MRI done, and I'm coming back to the doctor to show him the MRI.
Hello again. So, did you get your MRI scan?
So yes, doctor, I got my scan done, and you know what? I googled the report, and it shows that I have an L4, L5 gap problem, and it sounds really serious.
Okay. Let's see the MRI. Can you put up the slide, please? So, I see you do have a disc problem. There is a tear in your disc at the L5S1 level, and your discs are degenerated. Basically, it means that your discs have lost their shock absorbing capacity. It is almost like a punctured tire of a car.
Oh, doctor, that sounds really bad. Do you think this will be a permanent problem? Will it ever recover?
So if you do not take proper care, it can lead to a slip disc, and that in turn can cause paralysis and even loss of your urine control.
Doctor, that sounds really serious. What should I do to not have a problem?
So at this stage, the patient wants to know how to avoid a future problem. And how many of you agree with my assessment that this disc bulge or the annular tear is the cause of the current patient's issues?
How many of you in the audience agree with the doctor's assessment that the back pain is because of that annular tear or the disc bulge, and agree with the way he explained that MRI to me? Anybody in the audience agree with the doctor? Couple of hands. How many of you don't agree with the doctor's assessment? So far majority of them are disagreeing with the doctor's assessment, and Nandan will tell us why most of you are right in the audience.
Good morning, everyone. Thank you to the chairpersons and the organizers for this opportunity. So today I'll be talking about when do we scan in cases of low back pain and the damage that is caused by unnecessary imaging. So the learning objectives of this talk are: what are the criteria for ordering MRI scan, and more importantly, using appropriate language to interpret these findings. So as the previous speakers have elaborated, low back pain affects almost 85% of the population at some point in their life. Fortunately, majority of these patients will recover spontaneously. Unfortunately, there has been an increased incidence in spine surgery that is probably paralleled by the increasing use of spine MRIs. Research shows that alarming 50% of spine MRIs are actually inappropriate. The reasons may be many. Frontline physicians, general practitioners may not be aware of the current guidelines where you image. There is a misconception that this is safer than other imaging like X-ray or CT without radiation, and so it is widely prescribed. There may be variability in training. We are skipping clinical exams, and modern problems like defensive medicine, fear of litigation, so that leads doctors to over-investigate. Point number 6 is like there are financial incentives which are true in today's era, where there may be some imaging centers that may be tying up with doctors. So there are a few common clinical scenarios that we face. So this was a patient with sciatica who was referred to me, and the MRI scan was something which was there on the left. But a clinical exam revealed that his problem was actually in the hip, and a repeat MR scan showed avascular necrosis. We are sometimes prescribing wrong side. So this was a case with a previous discectomy that was done, presented with low back pain and multiple symptoms. Patient was re-prescribed an MRI scan, but on clinical exam it was found that his actual problem was in the cervical spine, so the wrong site may be mentioned in imaging. The last point is, many a times we do find benign findings in the MRI, like a hemangioma or a Tarlow cyst. Unfortunately, the language that is used in the report may cause unnecessary panic. So that's the second part of the talk, wherein these MR scans cause panic due to the incidental findings. So this is like a snowball effect. A patient presents with chronic low back pain. The orthopedic surgeon or his other primary care physicians prescribe an MR scan, which is probably inappropriate. This MRI is then reported by the radiologist, who has no clinical knowledge or what is going on with the patient in terms of his symptoms, and that leads to a routine MRI report. The patient then accesses the MRI report. It has words like annular tear, disc degeneration, etc. He seeks information about these terms from Google. Ultimately, that causes panic. Results have shown that this in turn leads to poor functional outcomes and response to conservative treatment. The patient is convinced that if he goes for a procedure or an intervention, that will cure his low back pain. So in order to mitigate this issue, there are clear-cut criteria where to order the MRI scan. The American College of Radiology recommends imaging for patients who have failed up to 6 weeks of conservative line of treatment. And obviously, as Dr. Agnivesh sir said, patients who present with red flag symptoms obviously require some MRI investigation. This was an interesting study that was published in the Spine Journal. It showed that patients with non-specific low back pain have a higher prevalence of structural abnormalities on MRI scan. So these structural abnormalities may be many, like a bulging disc and the other changes that we described. Fortunately, they do not have any negative influence on outcomes of conservative treatment. So using correct terminology and language to describe your MRI report becomes important. This was a paper by Rajsekharan sir, which shows that there are multiple terminologies which cause anxiety and fear. These include degeneration, tear, fissures, etc. So they recommended, instead of using these terminologies, replace it by a clinical MRI terminology, where instead of using words like disc degeneration or desiccation, you describe it in terms of the modified Furman's grade. Instead of using annular tear and annular fissure, you call it a high intensity zone. In place of canal stenosis or narrowing, you classify the lumbar stenosis based on Chiza's grade. So the authors concluded, routine MRI reports produce a negative perception and poor functional outcomes in low back pain. You replace it with focused clinical reporting that has significant benefits. So clinical reporting rather than image reporting has better outcomes of conservative treatment. So this is the ideal way or the flow chart which has to go. Patient presents with clinical chronic low back pain. Clinical exam identifies that there are no red flags. You educate and reassure the patient. Majority of the patients will improve and an intervention is avoided. Minority will continue to have the back pain. At this point, you request for the MRI and provide some clinical background to the radiologist, who will give you a clinical MRI report. You explain about the incidental findings to the patient and reassure him. Again, majority of the patients will improve and an intervention is avoided. So the take-home message is, avoid advanced imaging for patients without red flags. Strictly follow criteria, ACR criteria while imaging. While explaining findings, use reassuring language and do not cause unnecessary panic. Words like tear, degeneration, fissure, damage, these cause panic and they should be avoided. So thank you everyone for a patient listening.
Thank you, Nandan. You can come back and be the doctor, the bad doctor. So this is the last scenario. We'll discuss about treatment. So doctor, now that you have seen my MRI, what do you think I need? How will I get better?
This looks something serious, so we'll need to hospitalize you, put you on some pain medication, steroids, and also give you some lumbar traction. Probably that will make you feel better, but in the future, you will not be allowed to bend, lift, or participate in any heavy activity.
Will this cure my problem? Will it ever happen again? And do you think I'll need surgery for this in the future like my father did?
So if you do not take proper care, you lift heavy weights, you bend and twist your back, this can lead to some sort of surgery. We may even need to do an endoscopic discectomy for you.
I have a small child, and do you think it's wise to lift my child because she's just 2-year-old?
No, I do not recommend that. It can lead to permanent damage to your spine.
And how long do you think I should avoid and take bed rest? When will I be able to resume work? Will I be able to do my normal routine work?
It is difficult to say at this point, but there may be a prolonged time of activity restriction.
Okay, thank you, Nandan, for this. So with that, we'll ask the audience the question, what do you think will be the treatment option for managing me as a patient who has severe back pain? How many of you agree with the doctor's assessment that I need strict bed rest or traction or IV medications, narcotics, all the above or none of the above? So we'll just say raise of hands for all the above. How many of you all the above? A few hands for all the above and none of the above. So again, the audience is very wise. I think the answer is right. It's none of the above. So I'll invite the next speaker. Dr. Heath Matthews is actually unable to join us live from Australia, but we'll play his recording. So you can start the video recording of Heath Matthews. It's a video recording. So Heath is a physiotherapist who deals with these kind of patients, and he's going to tell us what is the appropriate treatment for such patients. So in all these 3 skits, you know, the doctor has made several errors in terms of you know, explaining the problem to the patient who has a benign sort of back pain, and made it sound more serious, that has scared the patient into believing that something is seriously wrong with him. So instead of reassuring me, the matter has been escalated. So this is what we mean that by saying that, you know, an excessive exposure to healthcare and a flood of incorrect information on the internet leads to more problems when we are treating the usual kind of back pain that far majority of patients would suffer. Serious pathologies causing low back pain, even if it is very severe, are very, very rare in healthy people. So we will start with Heath's talk. Can you play?
So, Ram sir, can I ask you one question? How many of the patients who come to your OPD, you see this annular tear, who sort of are actually symptomatic for this annular tear?
Well, truthfully, I see the annular tear towards the 20th minute of my consultation because I read the report last. I have clinically evaluated the patient after a detailed history taking, gone through the entire ritual of every step, and I work against the phantom. What I mean of working against the phantom is that I still believe in wearing my undergarments below my trouser, unlike phantom who wears the undergarment on front or in front of or above the trouser. So I do an X-ray first, followed by an MRI. I'm actually perplexed as to how we've had so much of discussion of MRI. We always need X-rays first. X-rays pick up things that MRIs at times may miss. Then I see the MRI after having clinically assumed what I'm looking for. So I have a mental assumption that I have to look for a neurological problem, an infective problem, a neoplastic problem, or none of the above. I don't use the word non-specific back pain. I hate 2 words, non-specific back pain and failed back surgery. I do not use them. So I look for pain which cannot be explained by things known to me, and I don't call it non-specific. Yes. Do I see annular tears reported? Yes. Do I see nerve root compressions reported? Yes. However, that's towards the end. Why do I do that? Because there are times, believe me, there are times we may have missed something which we have seen through but have overlooked. So I still read, and there is an annular tear. The annular tear will be only painful in the first few days after it has occurred. And very rarely, unless it's a high demand patient, will that patient come with an MRI in the first few days. So HIZs are reported, which are actually annular tears, but they are seen for a prolonged period of time, do not necessarily remain painful. So I beg to differ if there are people who insist that there are painful annular tears, except within the very first few days after an annular injury.
Can you give
Please introduce yourself and ask a question, sir.
Sir, I'm Dr. Satyan Mehta from Mumbai. So my question to you is, can you give me some examples of conditions which are clinically significant, which you may catch on X-rays, which you will not catch on MRIs?
I love you, Satyan. I strongly believe that lysis is picked up much better by us on plain films, on obliques, as well as lateral flexion extension films, which we may miss on MRIs. Very few of us insist on the intermediary CT scan. Lysis is something we miss. A lot of instabilities we miss. Degenerative listhesis we miss. A few incidental things like atropism, etc., we miss. The extent of degenerative lumbar scoliosis we miss. So there is more than enough that a plain film picks up. Plus a whole spine and positioning and dynamic films is extensive. I am a big follower of doing plain films. I may not do 16 plain films as few people do, but I do about 2 to 4 additional plain films.
Hello everyone. Let me talk today to you about lower back rehab. My name is Heath Matthews and I'm a sports physiotherapist and I practice in Bombay. So very, very quickly, a couple of statistical pieces of information. 80% of the adult population of the world will have lower back pain at some point in their life. Unfortunately, it doesn't stop there. 33% of those people who do get back pain will make a full recovery, but unfortunately, nearly 2/3 of that group will not make a full recovery and will have recurring lower back pain at least once more in their life, but on a very regular basis, as much as annually, could have multiple episodes of lower back pain. And a very small population of the group, 10% or so, will land up with chronic lower back pain where they have back pain more than they don't have back pain, which is quite an alarming statistic considering that you've got about 5.4 billion people that will get back pain in the world at some point in time. Right, so the majority of, or there's an increasing incidence of lower back pain the older you get. With the sweet spot being the population at around 45 to 60 years of age. And that does make a lot of sense because if you think about some very leading factors of reasons why we get back pain, a lot of these are associated with the kind of lifestyle that you're living between, say, 45 and 60, where by that stage you've lost a fair amount of natural fitness. Your core has weakened significantly either through childbirth or through the development of abdominal fat as you age and go, and your metabolic rate slows down. Obviously, our posture gets worse the longer we sit at desks, and just as we age, we tend to our posture tends to not be as good as we'd like it to be. Inflexibility plays a big role as well because as we age, we're not as active, so our muscles and our joints don't move through the ranges of motion that they should, and that general benign, slow stiffening of the body has a large impact biomechanically on the spine. As I've mentioned already, just too much sitting is just not healthy for us at all. Our postures at sitting at desks and at computers is horrible, and mobile phones these days all plays a big part in causing some kind of stiffening and disruption of the proper biomechanics of our spine. And of course, being overweight and unfit are huge factors in terms of not being able to manage the kind of forces that our bodies are subjected to on a daily basis. And that leads a lot to poor back hygiene. Bad mattresses, I can't stress this enough, bad mattresses and bad pillows and the impact that they have on our spinal column, particularly our lower backs. And then poor ergonomics at the workplace and poor footwear are two key factors as well that contribute to lower back pain. So the way that I approach all of my business is looking at movement. That's effectively what I am. I'm a movement specialist. And the way that I break down movement and movement pathology and how movement should be happening in the correct way is into 3 levels. The bottom of this pyramid is what we call movement competency. So these are the critically important components that must be in place to be able to move without pain. Then on that, we build what we call movement capacity, which is the ability to move repeatedly in the correct way for a long period of time without getting tired and then landing up needing to compensate and land up in a scenario where you can move with an inefficient and incompetent method. And finally, there's the skill, the ability to do something really well, or to do it okay, or to do it poorly. So skill is really where a lot of athletic people excel in sports, and you would land up with a large control of coordination, agility, speed, and power. But where we're mostly concerned as health professionals is the base of the pyramid: mobility of joints, flexibility of muscles, stability of the region, whether that be the shoulder, the hip, the lower back. The region needs to be well stabilized and moving correctly, and we need to have good balance and control of that particular area. So if we take that model of the pyramid and we superimpose that over what kinds of exercise and rehab and physical activity can we engage to be able to be good in certain aspects of the pyramid. The base of the pyramid is yoga, Pilates, rehabilitation exercises that physios and other rehab specialists will do a lot of, and any kind of low impact body weight exercise where we are not jumping, where we're not throwing, twisting and contorting the body and moving the body through high speed velocity based movements, but where the speeds of the exercises are much slower, much more controlled, much more attention is being paid to doing the movement with coordination and done in a safe manner without any exposure to pain. So the rehab specialist that you might be working with will spend a lot of time in this part of the pyramid using these forms of rehab and general fitness to improve the joint mobility, the flexibility, the stability, and the balance that we spoke about at the beginning. So they're trying to use yoga and Pilates and bodyweight exercises to make sure that the mobility is happening at this level within the pyramid. Now, if we take that a step forward and we look at how do we make that happen, then you can roughly divide it into three different phases. You can talk about an 8-week phase 1, followed by another 8-week phase 2, and then another 8-week phase 3. And you should say that the targets within the first 8 weeks after a back injury is to restore full joint mobility within the lumbar spine. Even the thoracic and cervical spine should also have full joint mobility. You should definitely make sure that the hips are fully mobile in all ranges of motion. And I would even say that the shoulder joint needs to be looked at to make sure that the whole area that may contribute to poor biomechanics in the spine, leading to unnecessary pressure on facet joints and discs, is controlled within this first 8-week period, because that gives us the best chance of making a full recovery and also gives us the best tools to being able to prevent a recurrence of lower back pain. Muscle flexibility is critical, particularly key muscles like your iliopsoas, because you sit too much, your piriformis muscle, and your quadratus lumborum muscle. These are very, very important muscles to be free, flexible, and working correctly, because if they are not, they will tend to spasm up and they can completely change the biomechanics at the lumbar spine, causing a lot of unnecessary load on the discs. So all of this contributes towards good core and hip stability. That is really what we're focusing on achieving in the first 8 weeks, is that the core must be strong and the hips must be stable and mobile, so that you can then give somebody the best chance of being able to move. On that, we build phase 2, which is building lumbar pelvic hip strength and endurance. So not only can you move correctly, but you can do it all day, every day, 365 days a year. And then finally, if you're dealing with young, fit, active individuals, you need to really make sure that their shoulder girdles and their lower legs, all the way down to their knees and their ankles, are also moving correctly, because that can have an impact on how their back works in compensation for those other areas. So in order to build a physically robust program for somebody and tell them in the next 24 weeks, we're expecting that you're going to be fully fit again with very little chances of recurrence of your lower back pain, you need to expose them to enough exercise, enough variety of exercise, that you build really good, strong joints and regions within the body to prevent this from happening. So for me, an absolute bare minimum would be 15 exercises in one workout routine done daily in the first 8 weeks. And my personal preference is to 3x that. I would easily do up to 50 exercises in phase 1. But generally speaking, if you're doing at least 15 different exercises on a very, very regular basis, covering all the movements that are required for the lower back and the hips, you should be on a very good path to recovery. Phase 2, you need to look at least 30 different exercises across 2 different workouts done as often as 4 days a week. And then in phase 3, you should be at a bare minimum of 50 different exercises across 3 workouts done at least 3 days a week, so that you've got enough exposure to this exercise to keep the joints loose, to keep the muscles flexible, and to keep the muscles strong and working correctly. So some brief examples, we can talk about joint mobility. Areas of concern are the thoracic spine. We need good extension and good rotation within the thoracic spine. In the lumbar spine, we need good flexion, extension, side flexion, and rotation. All movements of the lumbar spine are critically important. And then within the hip, you need very good extension and rotation and adduction. They're also very, very important components. If you're looking at general slings of muscles, if you talk about the anterior sling, which is basically connecting the anterior chest to the abdomen, to the hip flexors and down into the thigh, all the muscles and connective tissue of the front of the body, they need to be able to flex and extend as a unit very effectively. And if you talk about the posterior sling, you need the lumbar paraspinals, the glutes, the hamstrings, and the gastrocs to all be flexible and also be able to contract as a unit to be able to cause extension effectively. So these are all questions that you can have with your rehab team about, are we addressing all of these key critical movements? If we talk about the oblique sling, we're talking about the lats working with the quadratus lumborum, working with the glutes and the IT band, and making sure that they're working as a unit. And finally, your rotational muscles, again, the obliques, and how they work with the piriformis and iliopsoas and the abductors and adductors. And we want to move our clients through a progressive ability in terms of function. So we want to move from supine into all fours and side lying, and then prone, and then sitting, and then lunging and kneeling and standing, and then eventually into functional movements, whether that be daily functional movements or sport-specific movements. But making sure that people are competent to be able to stabilize their core and move their body efficiently in all of these different positions is extremely important. And you need to make sure that the rehab team are addressing all. So I hope this has helped to be able to explain the diversity that's required when it comes to movement, and how movement is so critical at preventing injuries. And actually, if we can move joints properly, we can have flexible muscles, and we can have muscles that work correctly, how we can prevent injuries to the discs and to the facet joints and this benign prevalence of high levels of back pain, then I feel that we can make a much better impact and service for our clients. Thank you very much for your time. I really appreciate it. If you have any questions, feel free to reach out to me. I'd be more than happy to discuss them with you at length. And I hope that the rest of the conference goes really, really well for you. Thank you. Bye-bye.
Thank you to Heath. Unfortunately, he's not able to join us live, but I'll now like to invite my co-convener, Dr. Ram Chaddha, to summarize the session for us, and maybe if we have some time, have some questions from the audience.
Questions from the audience. Please get up, introduce yourself, and ask 1 or 2 questions. Please, sir.
I'm Dr. Amit Bhandarkar. I'm from Sion, but I'm currently practicing in Southern Illinois, St. Louis area as a community-based practice. And this is my common patient clientele, low back pain. Just for the sake of balance perspective, I know you developed a narrative just to explain one side of spectrum where you kind of stop short demonizing MRI and, sometimes dismissing early intervention. So I think one of the major problems we deal in our part of the world, and just for the sake of balance perspective, I think MRI is a wonderful tool, offers a lot of diagnosis. Why diagnosis is important? Because a lot of patients go into chronic pain. So what you discuss has to have a lot of modifiers, acute versus chronic pain. One event of a doctor session versus a multiple subsequent event. Is it a global phenomenon of pain, or is it a focal phenomenon of pain? One of the pride that we have up there as a spine surgeon is that we are primary preventers of chronic pain, and the primary prevention of chronic pain happens by early diagnosis. And MRI is a wonderful tool of identifying the anatomy which is at fault. As we localize the anatomy, we can go ahead and be minimally invasive towards this. This is the whole philosophy towards the minimally invasive surgery. So I think MRI has a lot of advantages. Early intervention has a lot of advantages. And I think the major issue here is a cognitive behavioral therapy, which according to the NICE guidelines is very essential, is that the patient needs to understand that this is relatively benign. And every patient has to have on an algorithm an early course of conservative management. But subsequently, MRI definitely has a role. So I think painting a picture where MRI is really bad may not serve the purpose. But I understand for the sake of narrative, there are a lot of overuse and abuse of MRI. And I completely agree with that. No pain is non-specific. We have an immense burden of finding where the problem is and try to finding the pathology. I think one last comment is that we are missing out also in the treatment slide a very important arm of the algorithm, which is interventional pain management. I think there are very few things that provides the objective evidence of a pain-generating pathology. A intervention in the form of injection is very benign, is easily can be done. And I think with the help of C-arms, we can do it easily, and we can understand if the patient's pain is objective or not. There are a lot of patients who have a lot of pain generators, global and focal. I think one of the key points is to identify them. I think we need to integrate a little bit of this pain intervention into our spine practice.
Thank you very much, Dr. Bhandarkar. They are very, very, very valid points, and we appreciate your inputs. Anybody else? Any inputs from anybody? If not, I think in the interest of time, we should sum up the session. We appreciate that each one of you was here, and we strongly believe that non-specific low back pain, as it's addressed today, is called non-specific because today, as of 11 a.m., 29th of December 2022, we do not have a cause which is giving the effect. Does not mean that few years hence or few decades hence, we may not have the cause. So it's basically our ego which needs to be rested, rather than saying it's non-specific and letting the patient suffer or undergo what is called as unwarranted therapy. Yes, go for a pain block. Confirm whether there is actually something more than you know and treat it. However, as surgeons, 2 things we need to remember forever. 1, we as surgeons can only alter anatomy and believe that that alteration of the anatomy is going to alter the physiology. So till you are convinced that the alteration of the anatomy is not going to necessarily alter the physiology or make the patient functionally better, hold on. Next, back pain, leg pain, a lot of it is in the dynamic mode. Most MRIs in our country, and I'm saying most because I'm aware that there is one which can allow functional loading, are supine MRIs, and we need to actually add functional imaging like dynamic X-rays and collate it in there before taking a decision which is dynamic. So with these 2 points, one, that MRIs are actually done in the most pain-free situation of the patient, and that X-rays can actually at times mimic or probably create a scenario or a narration that we just showed, which could be more dynamic. Combine the two. Look for the outliers like the sacroiliac joints, look for the hips, look for thoracolumbar junction or lower thoracic spine in low back as well, and keep these at the back of your mind before jumping to a conclusion of what's in and what's out. I thank you all for a very, very patient hearing. I thank all the participants here, and I would just want Priyank to officially set this session as called for the day. All yours.
Thank you so much, everyone. It was a wonderful session on a topic which has been bothering orthopedic surgeons for decades. I hand over to the MC for the next session. Thank you so much.